All right. Okay, I'm going to go ahead and show my screen here. So can everybody see on your screen, can you see the beginning of the slideshow presentation?
Yes, we can.
Okay, excellent. Every time I have a fear that something happens with technology and I'm just talking to, out there to no man's land. But first of all, I want to welcome everybody. This is part of the Emergent Vision Therapy series. We've gone through kind of the basics of vision therapy, and now we're going to kind of go through session planning. So we're going to take an individual, and we're going to start very simple with somebody that it has maybe convergence insufficiency, or what we'd call a basic skills case, and kind of go through how we would plan that out week by week. And we may not hit every single week, but kind of some of the developmental benchmarks that we're looking throughout vision therapy. And then we'll start creating some different ones, taking parts of different clinical aspects for harder diagnosis as we go. I would also request, if you ever have a topic or something that you would like to see one of these webinars discuss, please either email me or call me and we will put that on the list. There will be a couple breaks during the sessions. Like next month, we're going to be doing a session specifically for those that are going to be doing their oral reviews at COVD and how to prepare for the oral review. So this is week 1 of session planning, and we'll go ahead and get started. I am James Smith. I am a COVT. Also work with Dr. Winters at Emergent, and I am currently the chairman of the COVD committee for the mentorship committee there. And so this is what I do. This is kind of my passion, is to try to get discussion and education on vision therapy out for vision therapists so that we all can learn from each other and we can just begin to promote what vision therapy is, and as therapists create this career path that will get each of us growing a little bit better in our vocation. So the very first thing that I want to talk about is that first session that we're going to have with our patient. We have to begin with identifying our patient, okay? And this is a quote that Sir William Osler said, and it was given to medical doctors, but I think it really impacts anybody in the medical field. And so I normally don't try to read what's on a screen, but I think that I'll go ahead and go through this. It says, the good physician treats the disease. The great physician treats the patient who has the disease. And we talk a lot throughout vision therapy that we don't see diagnosis, okay? We don't see CIs, we don't see strabismics, we don't see esotropes or exotropes. We see individuals that have exotropia. And so in a way in our brain and who we are, it kind of has to have a split section where we see the diagnosis, we see what the problem is and how to help that problem and what we need to do to take place and all those aspects. But we also have to have a place in our brain and in our psyche that we see, well, this is an individual, this is a person. And so the great physician understands the patient in the context of that patient's illness. For you as a physician reader to take this challenge to be a great physician, understand the full story. And if you allow me, I want to give a little bit of a personal insight into that. I don't know if everybody here knows, but I'm also a firefighter. And a number of years ago, my pager went off. It was like 5 something in the morning. It was kind of a cool morning. I live in the Yakima Valley, and we are surrounded by apple trees and cherry trees and all the soft fruits and just the produce that is around us is incredible. And it was during a time where a lot of the workers were going into the fields very early in the morning doing what we call thinning, where they're taking some of the apples off the trees so that the apples that remain can grow bigger. Well, again, about 5 something in the morning, the alarm went off, the pager went off. I got up, I got into my vehicle, and I saw that it was actually on my way to the fire department, to the firehouse. And so with my stuff in my car, I drove to the site. And when I got there, there was a car that you could see that was rolled over. And then looking off to the side in the bar ditch, I could see a car seat of a child's car seat. And anytime a firefighter sees that, immediately, the fear begins to rise up within us. And I looked over, and one of the ambulances were already there, and we had one fire truck there. And when I hopped out, I looked, and the ambulance had the child in the yard of the house where this crash had taken place. And I asked them if they needed anything, and they said, no, we're good. And so I continued towards the vehicle, and that's where the mother of the child was. And she was out on the ground, and at that time, my battalion officer was there, and he was just what we call holding C-spine. He was holding the head, making sure that she didn't move her neck. And when I came upon that scene, and I got there, I immediately asked, what do you need me to do? And unfortunately, during the wreck, her had to come back, and she had scraped part of her head, and it had caught on the seat belt. And I won't describe the injury, but just to the fact that it was serious enough that we needed to do something about it before she made it to the hospital. And I remember my battalion officer looking at me and saying, James, I need you to get, the 4x4, the gauze, the wrap, the head wrap, and to, help in this situation, to go ahead and take care of this. And so I reached over and I grabbed the gauze, I grabbed the 4-ways, I got down on my hands and knees, and I went to start to do the work, and my battalion officer said, stop. And so I immediately stopped, and I looked at him, and he said, gentle. And I kind of looked at him a little bit, and I went back to do what I was going to do. And he said, James, stop. And I looked, and he said, gentle. And all of a sudden I realized I was, because of adrenaline or just because it was the situation that I was in, I was kind of going a little bit fast. And he realized I needed to slow down and look at the patient, not just the condition of the patient, and to just kind of go what was needing to go. On my way home, I'm also a pastor, and I always kind of try to go through the situations and see what happened and what I needed to do better and why what happened and all that's going on. And I remember on my way home, as I was reviewing in my mind, it was almost like I was able to understand, as a firefighter, I saw the problem. I saw what needed to be done. I was trained in what I needed to do to fix the problem. And I was ready to do what I was trained to do and to start to fix what I saw as the problem. But even though I saw the problem, I have the experience, I have the knowledge, I know how to fix it. The patient is the one who feels the pain. They're the ones that's going through the problem. And so my battalion officer was trying to get me to stop and not go by what I know to do, but to take a breath and really recognize and begin to connect with the patient, to where that I would have the sympathy and empathy to do what I needed to do in a way that would help the patient, but at the same time not hurt the patient any more than needed to be. And so I know that's kind of an extreme example, but it's the same concept. As we're going in to see our patients, we need to be able to, as a technician and as a therapist, to see the diagnosis, to see the problems, to understand what is going on. And we have the education, we have the training, we know what to do to fix it. But it always helps to stop and remember, we're not the one going through the pain. We're not the one that is facing the complications. We're not the one that is experiencing what that patient is going through. So this whole portion right here of identifying the patient is to get past the technical aspect and get to, do we know our patients? Have we understood them? And that's what's going to make you a great therapist. So to get to that context, who is the patient? What are the patient's goals? how might the patient's personal situation impact our treatment options? Okay, so when we think about who is this patient, does this patient have a name? You know, who is the person's? Knowing a person's name can make such a huge impact in that child's life, but also in our the way we connect. We have a little picture of a boy that's here on the slide, and if you look at that, you can see, you know, a cute boy, got a smile, maybe a little mischievous, you know, all these different things we can begin to identify, but until we give him a name. And so for a practice, I would like to you, in your mind, give him a name. Okay, what would you say this boy's name is? Now, we don't know this boy, we don't know what his name, but in your mind, I want you to give him a name. I gave him the name Antonio. That's just the name that I gave him. But I want you to give him a name and then recognize in yourself, just by naming a picture, how much did that change the way you relate to that picture? Because it is amazing when you meet an individual or you talk to an individual, once you have a name and establish that social connection through a name, it does change how you interact with that individual. And so making that person's name, learning that person's name, helping to remember that person's name throughout the time that you're with them in therapy. What's the name of their parents? What's the name of their siblings? What's the name of their pets? You know, all those things can make a real difference. Who is the patient? Identifying the age. We know that age brackets are going to mean different things for us as therapists. Whether it's a little boy or a little girl, how that's going to work, whether it's an adult, you know, all those things. Maturity level. Maybe you have a 13-year-old boy or a 14-year-old, but yet their maturity level is based lower. I had one parent that they came and we're kind of talking about it, and though they were, I think, 11 years old as the time that I saw him, they said one of the things that we're struggling along is that he's acting more as a 6-year-old throughout school and throughout social interaction. So trying to judge that maturity level and finding out what's their education. I work in an area that we have a lot that English is the second language, and some of the kids that we have, they've actually just come from Mexico, and finding out what education that they may have not even done much school in Mexico, they come to the United States, and all of a sudden, because of their age, they're put into the 3rd grade, but really they're at a 1st grade education level. So understanding that. Then question marks. You could probably come up, and if anybody wants to shout out something, identify your patient. Who is what's another thing that you would be looking for that would help you to identify a patient? Go ahead, Stacy.
Things like what they enjoy doing.
Okay, good. Okay. Anyone else? All right. So then at the end of that, then yes, I do need to know what the diagnosis is. Okay. I need to know what the doctor found out, what the doctor is saying is the chief concern, and then, you know, all the different things that come down for that. Then going through our list, what are the patient's goals? And then also, what are the parents' goals? It's really fascinating to me as I go through, we have a list of goals that we go through, and one's reading speed, and then it goes through all the way to sports and activities and hobbies and less headaches and all these different things. And I have the parents fill out a goal sheet separately from the patient. And then I have the patients fill out a goal list. And it's interesting how many times that those are the same, but it's really interesting how many times those are different. And the priorities of the child or the patient are not always the same priorities of the parent. So taking in both of those goals, okay? Then when we think about goals and abilities, that's that behavioral development aspect versus the functional aspect, all about the numbers, getting to see 20/20, getting 20 seconds of arc. But the behavioral development is, you know, maybe it's just a remediation of symptoms, or maybe it's just getting them to their peer group to be able to have better interaction, you know. So all these things are good for us to flesh out right at the beginning. I also ask you know, why does the patient want to take vision therapy? Okay, why would they want to? What would make a difference? What are they hoping to see different? You know, a lot of times, and we'll talk about this in just a moment, I have patients that come in and they don't even know why they're there. Their parents brought them and they don't even know. And so explaining vision therapy enough to the patient so that they can begin to say, oh, I would like to take this because I would get better at. Okay. Some kids want to get better at school. Some kids want to get better in their athletics, whether they're a baseball player, football player. Some adults, it's recreational, or some parents, they want social, you know, their kid to have more self-esteem. They want their child to be able to function more in society. And then some people have personal reasons, what they want to do and how they want to improve. Then how might the patient's personal situations impact our treatment options? Okay, so other diagnoses, if they have cerebral palsy, if they're somewhere on the spectrum, that's going to affect it. Medical conditions, I've treated people that were wheelchair bound. Well, that's going to affect vestibular activities. Other hearing issues, that's going to affect some different things. Home structure. Now, this is one that can be really, you know, you gotta tread lightly, but I've had situations where I've had split homes. And so sometimes mom brings the child, sometimes dad brings the child. And that gets really interesting because home activities didn't go well. Well, mom says it was because he was at dad's house. Home activities didn't go well because that's because dad said that mom did this. And you have to be really careful how you navigate that. We had one situation where mom would bring the child, but dad would pick the child up, and mom and dad did not get along. And so part of the, you know, going over home activities was always interesting because you never knew what was going to happen between the parents. And so home structure, other children, families that have multiple families living in under one roof, those things will affect how they're able to do home activities and who's going to help them and all those different things. Limitations within themselves, idiosyncrasies, just different things that are kind of the quirks for the child. I like to let the child go jump on the trampoline, and then I'll ask the parents and I'll say, hey, what are some things about your child that I should know that would help me to relate to them better or help me to communicate to them better? And that gives the parent the opportunity to say, well, you know, this is one thing they like, this is one thing they don't like. And so that helps me to look at those things. So how that patient's personal situation impact. The picture, I purposely put the silhouettes because the silhouettes are the unknown. What's going to fit into that picture that's going to make up your patient's life, their school life, their home life, their family life, all those different things. What kind of silhouettes fill in the gaps? And that's going to impact how therapy is going to go through, or that I'm going to be looking at doing therapy with a child. So now we also have to get to the technical stuff. Okay, so when I think about having a new patient, so I would get on, we use Crystal, and so I would get a notification and it would just pretty much, James, you're going to be starting a new patient on such and such a day. So I would go into that patient's chart. I would look at what their name is. I would look at the names of the parents. I would try to find out as much information. I'd read their health history, all that different things. And then I would go to the doctor's initial exam results, because these are things that are going to kind of give me a clue a little bit. Now, again, we're kind of holding this to somebody that is a CI or a basic skills case for this first scenario, but things that I'm looking for, first of all, I'm looking for, you know, their RX. Is this child wearing glasses? If they are, why are they wearing glasses? So just briefly, the first example we have, somebody that in their right eye, they're a -2, -175, axis is 20. Left eye is -175, -125 still, axis 183, okay? What would that tell you? Maybe somebody that has a little bit more experience, or even a new person, you wanna try it. What would that prescription kind of tell you right off the bat that you're gonna have to prepare for this child? Please don't be shy. We want everybody to participate that will. Okay, let's break it down. Is this person myopic, or do they have, are they nearsighted or farsighted?
Nearsighted.
Nearsighted, right? Okay. That second thing there, that's cylinder, right? So that means they have astigmatism, okay? And then the last number is giving us the axis of that. So when I'm looking at this, I immediately know, what if this child showed up and didn't have glasses? Would they do very well at distance heart chart?
No.
No. Okay, so I know that this is a child that I'm pretty much going to have to make sure that they have their glasses with them each time. And I also know that they're myopic, okay, and they have astigmatism. And so that's going to give me a little bit of idea of how, what type of activities I'm going to be working first in accommodation. Now, the second one, a +2, a -175, they have just a little bit of cylinder. This is the child that a lot of times they won't bring their glasses, okay? They can see pretty far out there, and they really don't care near. Maybe as a child, they still have a whole bunch of accommodation of capability, or they just get used to blur, okay? And so this is a child that a lot of times they won't have their glasses, but it tells me, you know what, that's a pretty basic prescription. I can probably get a trial lens frame and just put in a +2 on both eyes, and it's gonna be close enough that I can do therapy with them even without their glasses if I want to add it. Now, the last one, I know that we talked about, you know, we're really working with the CI, but if I saw a +4 and the other eye is plano, immediately I can see this person probably has refractive amblyopia, and that they're going to need their glasses for a lot of activities. And so that just kind of gives me some information before I even see the patient about what their visual system's doing as far as clarity, as far as accommodation. Okay, then I look at stereopsis. Now, the doctor is doing a lot of different tests, okay? And I'm just highlighting a few of them that I look at specifically before each time that I'm going to meet with a patient, okay? So stereopsis, we have near, they can use the RAND dot or the word circles, okay? I'm looking, if somebody has 200 seconds of arc, well, that would be the fly, okay? So they can kind of see that there's some depth there, but they really don't have good stereopsis. 80 seconds of arc, okay, they're getting better, okay? But it's still not fine-tuned. A lot of CIs are gonna be kind of in this range, or you may have somebody that has 20 seconds of arc. That's perfect stereopsis, okay? So knowing that gives me an idea of how does their binocular system work together before I even met the patient. I also look at to see what their distance stereo is, okay? Because a lot of the stereo tests are done at Harman distance, but how is their stereopsis in the distance? And your doctor can kind of show you how they do that. A lot of clinics, it's part of their screen that they can put up on their mirror, and they can run it with red-blue. Okay, then I look at the Worth 4 dot. Examples that the doctor would have in notes are fusion at all distances. So I know that, hey, this person is really good to go. An example that I would see a lot of times with somebody with a CI is they have diplopia to 8 inches. So inside of 8 inches, they're diplopic because they have a hard time getting their eyes to come in. And then if you get it past that 8 inches, then they have fusion at all distances because they're past that point where they're having trouble to converge their eyes. And then the third example is maybe they have diplopia to 6 inches, then they have fusion from 6 inches to 4 feet. And then as soon as they hit 4 feet, they have suppression in the left eye beyond 4 feet. And that could be because they are exotropic and they're able to hold it, you know, and then they have divergence excess. Once they get to that 4 foot mark, that eye just continues to turn out. So it kind of gives me some information on where they're suppressing or where they're able to hold both eyes together in fusion. Any questions on any of those? Okay. So then I look at the NPC, so the near point convergence test. Example 1, we see what we'd say was probably perfect, you know, 1 to 2, 1 to 2, 1 to 2. The first number is where they're able to get to before it splits. The second number is as it comes away, where they're able to recover. And so a lot of times you think about one, you have to remember the measurement from the eye, okay, to the nose, okay, so that's usually about 1 inch. So if you're to the nose, then it would be 1, and then recovery is, 1 inch away. That would be good. Or some people will put it, TTN is just to the nose, to the nose. They never have diplopia. They never have to recover. Okay. Example 2, as it's coming in, 2 inches away is where they get diplopic. And then as you pull it away, the 4-inch mark, that's when they're able to get it back. But the second time they did it, it was 2 to 3, and the third time they did it was 1 to 2. So once they figured out what the doctor was wanting them to do, then they were able to perform it. The first time they were trying to figure it out. The second time they got a little bit better. The third time they are actually able to do it perfectly, okay, or do it well. That would show you somebody that just doesn't know what their skills are and they're needing to learn those. The third example is 2 to 4, 3 to 5, 5 to 8. So each time it got a little bit worse. So the ability to bring those eyes in, the first time they were able to crank it in and do it, but then they fatigued really quickly. And on the second and third time, it got worse and worse. So they were having a hard time. So that NPC lets me know some information. And then you have your negative refractive accommodation and positive. So if you look at the first example, the NRA is a plus 125, PRA is a minus 175. Remember that optometry, everything's a little bit backwards. So negative means that we put plus in front of them, and so they have to relax their eyes. Positive means that we put minus in front of them and they have to flex their accommodation or use their accommodation, okay? So example 1, a plus 125 and a minus 175, that is their amplitude. That's how much they can flex in or how much they can relax out. And these would be kind of a low threshold. We'd like to see those numbers higher. So we can see that they're having a hard time flexing their accommodation. They're also having a hard time relaxing their accommodation. The second example has a plus 1, a minus 350. So they were really able to flex their accommodation in, but they had a hard time relaxing their accommodation out. So that's going to trigger in my mind, hey, be careful. This patient may have a little bit of accommodative excess. They could be a little bit prone to accommodative spasm because they're able to flex in on that minus, but then they have a whole, just trying to relax their eyes out is going to be a problem with them. And then the third example is what we'd like to see is that they can relax out plus 250. So if you're at Harmon's distance or 40 centimeters, a plus 250 is going to take them out to infinity. They're totally relaxed. Also a minus 350, they're able to bring that in quite close. Okay, so that would be a very strong accommodative system. Okay, then accommodative flexibility. We use the vectogram number 9. It has the circles around it, and then it has the letter charts in the middle of it. I think it's the center line, which is line number, I think 6 is solid all the time. 4 and 5 is left eye or right eye. And so you can sit there and rock back and forth. You can do it monocular or you can do it OU. So OS, you have them pick a line. You pick a line for them, and then plus minus you rotate it back and how often they can clear that, and so how many cycles. So it's the number of seconds that it takes for clarity is what I'm looking for. Then the right eye, number of seconds for clarity, and then both eyes. So sometimes you'll see that left eye is 1 to 2 seconds, right eye 1 to 2 seconds, and then the OU 7 to 9 seconds. Okay, so monocularly they can get that flex and relax, but as soon as they try to do it binocularly, then they're really struggling to know how to flex and relax that accommodation, probably because they don't know how to do it separate from their convergence system. Okay, so this is a good information on how well they can have that flexibility of going in and out with their accommodation. Other heart or chart notes that I'm looking at from the doctor is ocular motor movements. He'll put head movement, like if they're moving their head. If it's a young child, not too worried about that. But if it's a teenager or an older person and they're still having head movement, then I know that they're a little bit delayed on that. Fixation loss, if they're not able to hold fixation. Jerky eye movements, is that neuromuscular coordination, or is there a lot of jerky eye movements? Looking at, and then also our doctor also puts observations on posture, mental status, all those different things. Those are really good to look at, because if the doctor gives you all these numbers, but in his notes he says patient had a hard time sitting still, patient was up and down out of the chair, patient was distracted, well, that's going to prepare me, because that's how that patient is going to do therapy. They're going to be up and down, they're going to be distracted. I've got to be ready for that. Or if patient was detached, patient was silent, patient didn't want to talk, patient didn't communicate, I need to know that, because that's probably how they're going to do therapy. Okay, so those observation notes kind of prepare me for what type of patient I'm going to have, and so that I know how to prepare to either engage them, or how to bring them down, or how to bring them out. All right, meeting the patient. And this is just kind of things that I do. Everybody has a different way, and there's probably better ways, and you'll find your perfect way. But I like to greet them at the front desk, and I like to greet them by name. Okay, I like to show that, I know who they are. I talk to them about looking forward to them coming, and how I've been excited about they're going to be this new patient. As they're coming through our hallway, we have pictures of success stories, and I will have looked at what their diagnosis is, so that when I'm going down that hallway, I can point out other kids that had the same issues that they did. And I can say, hey, if it's little Johnny, I can say, hey, Johnny, this is Tyler. Tyler was here a couple years ago, and he had just like you do. And this is his success story. And so I can kind of prepare them to see that, hey, other people have faced what I've faced, and they've been successful coming to this clinic. And so things that might correspond with their interest. If I know that they like baseball, I have different kids that I've taught, vision therapy, sports vision therapy too, in baseball, and I'll point out their picture and kind of give them that. And then when you come out back to your desk, I try to have a seat already prepared for the parents. The last thing you kind of want is to get to your seat and you have the place for the child and there's nothing for the parents to sit, and then you're kind of scrambling after the fact, and oh, by the way, here you go. The parents are very important at this first meeting time, and so you want to create that they're valuable to the process, and that's just kind of how I set that up. I go through the introduction speech. I'm not going to give you my introduction speech in this format, but you know how you want to do it, but really give them your name, but also how they can address you. Okay. A lot of kids are very, very polite, and they'll say yes, sir, to me, and no, sir, and all these different things. And so I kind of talk to them about how they can talk to me, or what they can call me, and a better way that they can just, say my name, or however we want to set it up. And then I like to, as I said before, ask them if they know why they're there. I've been surprised how many kids are like, no. And mom and dad are like, well, of course you do. And the child's like, no, I really don't. And so really giving them the example, or taking the time to really discuss why they're there and what we're going to do to help them. I try to go through you've come to the right place, you're working with the right people, we're going to give you the right product, and then we're going to go through the right program. That's kind of how I line it out for them. Okay. Handing out your kit, your supplies, create ownership. So whenever I give them therapy supplies and I give them that backpack that has all their kit in it, I really let them know, Johnny, this is yours, and have them take ownership in it. Because when they take ownership of some of the equipment, they also start taking ownership of the entire therapy practice. And, I'll even tell them, hey, I'm giving you this. It's your job to bring it back with you at each therapy session. I don't want to hear that mom didn't bring it or dad didn't bring it. Johnny, this is your therapy, so you're responsible bringing your stuff. And so it helps to create that partnership with them. Go through goals, find out interests, hobbies, I not only want to know this as a goal, but I also use it for relevant terminology and examples throughout therapy. So later on in therapy, if I know they're baseball players, when I'm doing Marston ball, I'll talk about how it will help them in baseball. If I know that they're soccer players, when I'm doing Maro reflex and toes in and toes out, I'll talk about how that will help them in soccer. So knowing their hobbies and knowing some of the things that they like, it changes how I'm going to talk. I had one boy that we would do Brock string. We would use all terminology of Transformers, okay? So red was Optimus Prime, yellow was Bumblebee, and green, I don't remember what the green was, but it was look at Optimus Prime, okay? So trying to find out things that connect to them. Then give a tour of your clinic. If they've only come to install the exam room and the front lobby, I take them through, I walk them around, I show them where the bathroom is, where the drinking fountain is, where side rooms are that we might use for therapy at later times, and really let them be comfortable. They need to be comfortable in their environment before they can really be comfortable in all the things that they're going to do, okay? Discuss VT, what you expect out of them throughout the course. My main thing is I tell them I'm going to be completely honest with you, and I want you completely honest with me. I can't see through your eyes. All I can do is what you go based off of what you tell me, okay? And then allow them to give any questions that they might have about vision therapy. Now, all right, so now all of that to get to what are the basics, okay? So my first day of activities, they're really more for my personal observation of the patient versus total instruction on the activity that I'm wanting them to do, okay? It's to assess their interaction paradigm, okay? How do they interact with the world around them? How do they interact with me? How do they go from task-oriented or instructions to the task? All these things I'm watching for that interaction. So we know the classifications of activities. We're not going to break all these down, but ocular motor, the eye movement, accommodation, binocular, and visual perceptual. So all these four things, these are what I'm basing each week. Do I have an ocular motor activity? Do I have an accommodation activity? Do I have a binocular activity? Do I have a visual perceptual activity? Now, in the early part of therapy, I may have more ocular motor than accommodation, or more ocular motor than binocular. But as I go through, I'm balancing through these four activities, making sure that I have a complete therapy practice or protocol for this patient. So this is my quote I live by. It's not the activity, it's the action in which the brain makes new neural connections, okay? So if I have them do an activity over and over and over and over again, but they're not making any new brain connection, it's just a wasted activity. It's a wasted therapy time. So every activity that I do, I'm looking for, is this causing neuromuscular conflict, neurocoordination conflict, and thereby making the brain do things different, okay, to get a different result. So I start with basic oculomotor activities, eye stretches, and most of you already know what those eye stretches are. I'm not going to go through every activity that we're doing here, but I want to remind you that eye stretches don't have to be done just with your fingers north, south, east, west, making sure that they think that there's a string that's tied to their fingers as it goes to the right, goes to the left, all those different things. But you can use wolf wands, you can use toys. A lot of little boys, I'll use Matchbox cars for ocular motor eye stretches. The things that I'm looking for is range of motion, okay? Teenagers, I'm finally giving you permission to roll your eyes. So every day I want you to roll your eyes and get that range of motion all the way around that circle. Smoothness of coordination. So if I'm doing an activity and I'm having them follow it, so a pursuit activity and eye fixation activity, I'm looking for that place where that eye begins to just kind of quiver, that jerky movement or just a little bit of that fixation loss. Don't just rush past that. Stop at that point and just kind of keep massaging that spot and then work your way until it's nice and smooth all the way around. So that's kind of from the very beginning. It's not how fast they can move their eyes and how far they can move their eyes. It's yes, distance, range of motion, but it's the smoothness, the control factor that they can do. And then an early one, first day is heart chart. I'm looking more for the ability to coordinate the ocular motor with the timing of the metronome, okay? So you have a heart chart, O, F, N, P, B, D. It's not that they can just read the letters. It's coordination is the right muscle to the right place, but it has to be at the right time. So we'll take some time with the metronome, letting them feel the beat, letting them hold the beat, having them, you know, even if they have to say their ABCs to the beat first, and then go through that heart chart. Most of the time, the first day I'm going to be doing this monocularly. So it's going to be patched. I use a translucent patch so I can see that opposite eye. Have them come up and touch that chart and then walk back that 4 to 6 feet, or just that borderline where it's just, you know, not difficult to keep clear, but right where they're trying to keep it clear, and work that ocular motor at that point, okay? CP saccades, central peripheral, put that chart up there, teaching them that opening their periphery, how to open it, and that sometimes opening the periphery, that sometimes less is more. So we'll even kind of use look hard, look soft with this periphery chart, okay? If they're looking at that center X and they really focus really hard on it, what happens to the letters around it? Versus if they look really soft, how much more they can see that peripheral, and getting that open, and how less parvo, okay, gives more magno and can open up that periphery for them. I will tell you this, CP saccades, a way that I really like doing it is when you do it on a whiteboard, you can put your X in the middle and the 1, 2, 3, 4, and you can put stars and hearts and symbols and all the different shapes, and you can put letters and everything else, is give them a dowel. I'll give them a dowel, and it had a little green thing on the top, and I'd have them put it on that X so that they're looking at it. And you can do this monocular or binocular. And then I would have in their periphery see where they're going. So if it was the number 3 over here, and then I'd say, now your little green car is sitting in the garage. You need to drive to the X without, or drive to the 3 without looking at the X. So they can use their periphery to drive something. So it's motor guided, or motor guided by vision, okay? And then when they think that that's there, then they can check it, and you can go through the protocol with it. But that's just a way, and then have them drive it back to the garage, okay? Bring it back. That way, if they're kind of hesitating or they're moving it and going in angles, it's very easy to talk about, oh, you just drove over the garbage can, or you just went into the neighbor's yard. You can kind of make it so that they can see when they're getting off in a language that can connect a little bit better. Very first day, first week, I'm not doing a lot of accommodative activities. If anything, it's just the exploring the feeling of an opened and closed periphery, okay? Look hard, look soft, and then just the beginning of how does it feel when you flex your accommodation? How does it feel when you lax your accommodation, okay? I'll do this with the heart chart, and, you know, have them look really solid right at the center of the heart chart. What happens to the letters around it? Have them relax. How does it look? Just that look hard, look soft. And so it's not totally an accommodation activity, but this is just the beginning, preparing them for bullseye, preparing them for flex and relax. Basic binocular activities that I would use on the first day is Marston ball. As it's going away, as it's coming towards them, I'm working on the feeling of space. Now, if you want, you can go to our YouTube channel, and if you don't have that channel, I can give it to you. But you can go to that YouTube channel. There's a whole section on this Marston ball that I just broke down. But you want them to feel, as that ball is coming in and they're converging, that compression of space on that Z-axis. But at the same time, you want them to feel the compression in their periphery, that everything is kind of collapsing, and then as that ball goes away from them, everything's expanding, okay? So they're feeling space on all those areas, how their vision affects the feeling of space. Then the feeling of convergence. Do their eyes feel different when looking at the ball when it's close, versus do their eyes feel different when they're looking at the ball when it's far away? So beginning that feeling of divergence and convergence. And then as the activity, we all know the 3 hits: palms, fists, thumbs. Now I will say palms, make sure you want them to hit it in the palm, not on their fingers. When I do fists, I always have the thumb up because that helps that radial nerve to be up to help in localization. And then hits, the thumb hit, you know, they're gonna just use the pad of their thumb. T catches, fist catches, and then we use what we call bird beaks. We just have them put all their fingers together and they catch the ball between their fingers. Then the other basic binocular activity that I'll do in week 1 is red-green lusters. So just putting red-green glasses on them, going to a whiteboard, letting them finger paint and do those centric circles as they grab the colors and mix them together. I'll give them a white balloon that I blow up and they can do balloon volleyball. Then we'll take that balloon and take them to the trampoline and let them jump on the trampoline while they're working with that balloon. And so that they're trying to hold luster on those white objects, okay? So these are the basic binocularity. Lastly, my visual processing, I just take a deck of cards, and that first week, they're just sorting it according to their suit, because that's really easy to send home. Most people have a deck of cards at home, and so it's an ocular motor activity, a visual process activity. You have recognition, identification, and processing. They're having to do something with the card. Then I also like blink cards, okay? Again, on the website, there's a whole section, or on the YouTube channel, there's a whole section on how I use blink cards, okay? But you can use blink cards, have them sort them color, number, and shape. So the first week for visual processing, it's just usually visual discrimination. I'm just having them sort according to piles. Hybrid activities, the SVI is a great one. You can set it on saccades and put it on alphabet letters, the red and blue, they cancel with red, green glasses. Have them sit on a yoga ball with a large dowel, you know, a long dowel that has a tip on it that they can touch the touch screen, and then have them just go through the alphabet, red, you know, and it'll alternate between. So it's a good anti-suppression check. It's a good balanced vestibular check, and it's a good ocular motor check. It tells me if they know their alphabet, all those different things, their scan rate, their pattern of scanning, direction of scanning. So these are a hybrid activity that I can use on that first day. If you'd like more information on that, feel free to call me anytime. It's one of my favorite activities, and so I'd be happy to talk to you about it. We're about running out of time, so let me just go over home activities real quick. So home activities, we do 20 minutes a day, 4 days out of the week. Things that I'm going to send them, that first week would be like the heart chart, because I showed them how to do it. Very basic, 60 to 80 beats per minute at the most that first week, straight across, okay? That's all I'm trying to get across. CP saccades, show them how they can do it on a window, show them how they can do it on a sliding glass door, you know, any way they can do that. And for our patients, they also have the Emergent kits, so they can do it on the back of their slant board on the white part. Then I give them any of the following. They can take their pick: mazes, sorting, dot to dots, hidden pictures, coloring, puzzles, word searches. All those things I tell the parents, these are free reign. You can do as much of these as you want. And so that gives them some ocular motor activities. All my ocular motor activities, I want something that has to do with visual guidance. And there has to be recognition, identification, and then processing, something that they do with the information. That's my goal. Accommodation. First week, I usually do not send any accommodative work until I've really established good flex and relax recognition and control. I don't send it home. If your doctor wants you to do something different, that's great. You work that out. Binocular, I'll send the Marston ball, the 3 hits and the 3 catches. And then I'll send the red green glasses with the balloon volleyball. So I'll send the balloon home with them. And then I do what's called passive wear. So I just tell them, hey, I want you to wear your red green glasses 10 to 15 minutes a day. Anytime that you want to wear it, you just put them on and just wear it. And this is just a way the brain knows that the world can't be red, it can't be green. And so this is a passive way to work inside that brain, that there has to be some way that the colors saturate together. So it's just, you know, non-active, just very passive. Okay, I think that is it. So I'm going to stop sharing that. Any questions or any comments or anything that somebody else would like to share? All right. I'll give everybody an opportunity. I appreciate everybody being here. I hope that it's something that you can go and incorporate. If you've been doing this for a while, you know, I'm sure that you have different ways that you would do the same things. That is the beauty of what we do. We have multiple ways to get to it. Next month, we will be talking about the oral review. So if you're a COVT already, I would love for you to come so that you can chime in on that and help